All right, let's jump right in. Today we're tackling a really important topic in gynecology, one that you'll definitely see on your exams: endometriosis. It can seem pretty confusing at first, but I promise by the end of this, you're going to have a really solid, high-yield grasp of it. So, let's start with a bit of a paradox, a real head-scratcher. We know endometriosis isn't cancer. If you look at the cells under a microscope, they're benign. But here's the thing, it acts a lot like a cancer. It can invade nearby tissues, it spreads all over the pelvis, and sometimes it even pops up in distant places like the lungs. So how can a benign disease behave so aggressively? That's the core question we're going to unpack today.
Okay, so what is endometriosis, officially? The textbook definition is pretty straightforward. It's the presence of functioning endometrial tissue. That means both the glands and the stroma, anywhere outside of the uterine cavity. But the key word here is functioning. This isn't just dead tissue, it's alive. It responds to your hormones, so every single month it thickens and then it bleeds. And that's where all the trouble starts, because that blood has nowhere to go. It gets trapped, causing inflammation, intense pain, and over time, a lot of scarring.
So, here's how we're going to break it all down. We'll look at how it starts, what it looks like clinically, how we can be sure of the diagnosis, and then we'll wrap up with a quick high-yield review to make sure all the key facts are locked in for your exams.
First up, let's get into the pathogenesis. The big mystery here is pretty simple. How on earth does this normal uterine tissue end up in all these wrong places? Well, there are a few theories floating around, but one of them is by far the most important.
And that theory is Sampson's theory of retrograde menstruation. You absolutely have to know this one. It's been the leading explanation since the 1920s, and it's still the best one we have for explaining most cases of endometriosis inside the pelvis.
It's actually a really elegant idea when you think about it. Imagine the flow of menstrual blood is like a river. Normally it flows out, but in retrograde menstruation, some of that river flows backward, up through the fallopian tubes and spills into the pelvic cavity. And it's not just blood, it's carrying live, viable endometrial cells. Think of them like seeds being scattered in a new garden. They land on surfaces like the ovaries or the peritoneum, they implant and they start to grow.
So, following that seed analogy, where do they end up planting themselves? Well, pretty much where you'd expect gravity to take them. The most common site, by far, is the ovary. After that, you'll find them in the dependent parts of the pelvis, like the pouch of Douglas behind the uterus. The fact that these implants show up in such a predictable pattern is actually one of the strongest arguments in favor of Sampson's theory.
But wait, Sampson's theory doesn't explain everything, does it? What about those rare cases where endometriosis is found in the lungs, or even in a C-section scar? That's where these other theories come in. Cholemic metaplasia suggests some cells in the peritoneum can actually transform into endometrial cells. Lymphatic and vascular spread is just like how cancer metastasizes. The cells travel through blood or lymph channels to faraway places. And direct implantation is exactly what it sounds like. Tissue gets moved during surgery. The key takeaway here is that it's likely not just one theory, but a combination that explains all the different ways this disease can present.
Okay, so we've covered the how. Now let's talk about the so what. How does this ectopic tissue, this internal bleeding, actually cause the classic symptoms that patients experience? Let's connect the pathology to the clinical picture. For your exams, you need to have the classic clinical picture down cold. Think of pain, abnormal bleeding, and infertility. The pain is really specific. It's what we call secondary dysmenorrhea, which means it didn't start with her first periods but developed later and gets progressively worse and worse over time. Infertility is a huge part of the story, affecting up to half of all women with the condition. And another classic symptom is deep dyspareunia, or pain during intercourse, which is especially common when there are implants on the uterosacral ligaments. All right, now for the stuff you can actually see. If you were to do a laparoscopy, one of the first classic signs you look for are these powder burn lesions. They're also called gunshot lesions, and the names are super descriptive. They're just small, dark blue or black spots on the pelvic surfaces, which are basically tiny, old bleeds that have been walled off by scar tissue.
And here's what that looks like in real life, a view from inside the pelvis. You can clearly see those little dark spots. Those are the powder burn implants we were just talking about. But I want you to look over at the ovary on the right. See that large, swollen cyst? That is the second classic finding we need to talk about.
Now, the proper medical term is an endometrioma, but literally everyone calls it a chocolate cyst. And once you hear why, you'll never forget it. It happens when an implant on the ovary bleeds month after month, but the blood gets trapped and collects, forming a cyst. Over time, that blood becomes old, thick, and dark brown, and it looks exactly like melted chocolate.
So, what does this look like on imaging? Well, on a transvaginal ultrasound, these chocolate cysts have a very characteristic appearance. You'll see this well-defined cyst, and the fluid inside isn't clear. It has this uniform, hazy pattern. The key phrase to remember for your exams is a ground glass appearance. If you see that, you should be thinking endometrioma.
Okay, so we've got the symptoms, and we've got these imaging clues. That's all great for building a case, for raising your suspicion. But how do you actually move from suspicion to definitive, confirmed diagnosis? Let's get into that.
First off, don't forget the power of a good physical exam. On a bimanual exam, you're looking for some key signs. You might feel general tenderness, or even specific, hard nodules in the pouch of Douglas. You might find that the uterus is retroverted, tilted backward, and feels fixed in place because it's stuck down by adhesions. And of course, if there's a large chocolate cyst, you might be able to feel that adnexal mass.
But, and this is an absolutely critical, high-yield point for your exams, so please lock this in. All of those things, the symptoms, the exam findings, the ultrasound, they only raise suspicion. They are not a definitive diagnosis. The one and only gold standard is direct visualization with laparoscopy, where you can actually see the lesions, take a biopsy, and have a pathologist confirm under the microscope that you're seeing endometrial glands and stroma.
All right, time for the home stretch. Let's do a quick, high-yield review to pull all of this together and clear up a couple of common mix-ups, so you're totally ready for any exam questions on this topic.
First, let's tackle one of the most common points of confusion: endometriosis versus adenomyosis. Students mix these up constantly. Here's an easy way to think about it. Endometriosis is like the wallpaper of the uterus peeling off and getting stuck on other walls in the house. Adenomyosis is when that wallpaper starts growing into the wall itself. One is tissue outside the uterus, the other is tissue inside the uterine muscle wall. Totally different locations, totally different conditions.
And please do not forget the powerful connection to infertility. This is a big deal clinically, and it's a favorite for examiners. While endometriosis might affect around 10% of all women, look at this number. Among women who are struggling with infertility, the prevalence just skyrockets to as high as 30 to 45%. That's a huge association.
Okay, let's do a super quick rapid-fire review. I want you to answer these in your head. Most common site? The ovary. Most accepted theory? Sampson's. The two classic lesions? Powder burns and chocolate cysts. The classic symptoms? Progressive pain, dyspareunia, and infertility. And the gold standard for diagnosis? Laparoscopy with biopsy. If you know those 5 points, you're in great shape.
So if you had to boil this entire topic down to just one single sentence for a quick revision, here it is. Endometriosis is a common, estrogen-dependent disease where ectopic endometrial tissue causes a chronic inflammatory state, leading to its cardinal features of pain, adhesions, and infertility.
And that brings us full circle, right back to that puzzle we started with. This strange disease that's benign on paper, but acts so malignantly in the body. The future of treatment really lies in figuring out how to target that unique, aggressive biology without causing major side effects. It's a huge challenge, and something to think about as you continue your medical journey. Thanks for joining me for this explainer.